Hi, Mike Gibson, talking about the precise randomized trial looking at a precision CT-based strategy versus usual care in people with chest pain. Mike, talk to us a little bit about the study, why you did it, and what the design was.
Well, first off, thanks for having me, Dr. Gibson, and for giving me the opportunity to highlight our work from Precise. I think I'll just start off by acknowledging the incredible PI for the trial, Dr. Pam Douglas, the amazing study team, our fantastic sites and study sponsor, and of course, all the patients who agreed to be randomized. This was a trial that recruited during the height of the pandemic, and it was quite the undertaking, but ultimately a success due to the phenomenal team effort. I think we all routinely take care of stable symptomatic patients with suspected coronary disease. It's an incredibly common clinical syndrome, but unfortunately, a population who often end up with multiple diagnostic tests and procedures, many of which may be unnecessary. So, I think many would agree that the prevailing diagnostic pathway leaves a lot of room for improvement. We also know from previous randomized trials, including Scott Hart and Promise, that a coronary CT approach has similar or better clinical outcomes compared to usual care testing. But one of the criticisms of a coronary CT approach in some of those prior trials, including Promise, was that it led to more caths. And there's this belief that the introduction of FFRCT can improve the yield of those caths by introducing what one of our colleagues, Dr. Mark, coined as so called physiologic discipline to the test. And so, for Precise, what we set out to do was to determine what is the optimal testing strategy in individuals being referred for further testing of stable chest pain. And specifically, we designed the trial to see if we could reduce excess testing in those lowest risk patients and reduce excess cardiac caths in those higher risk patients. And in order to do this, we evaluated what we called a precision care strategy using the validated PROMIS minimal risk score to stratify low risk stable chest pain patients to deferred testing and intermediate or high risk patients to a CT with selective FFRCT. And we compared that to a usual care strategy of non invasive or invasive testing based on the site clinician's determination. And it's important to point out that PRECISE is actually the first randomized study to assess the elevated role of coronary CT with FFRCT to guide treatment decisions that was proposed in the 2021 ACC AHA chest pain guideline. So we enrolled more than 2,100 patients in PRECISE across 65 sites with 1 year of follow-up. We had more than a thousand patients randomized to the usual care testing approach, which meant that these were patients who were already identified as needing further testing for stable symptoms. And that testing strategy, again, was selected by the site clinician, either functional stress testing or direct to cath. And that was based solely on their clinical judgment. And all subsequent care and testing was up to that clinician. In the precision testing strategy, we had more than 1,000 patients who, again, were assigned to either a low risk deferred testing approach versus CTA with selective FFRCT in the intermediate and high risk groups. And we used, again, the PROMIS minimal risk tool to base that risk stratification on. Our composite primary endpoint was MACE, along with cath findings without obstructive coronary disease, and we had excellent follow-up and very few protocol deviations. So, in terms of baseline
Mike, can I
characteristics,
ask you,
oh yeah, of
what
course.
is non-obstructive coronary artery disease? I mean, beauty is in the eyes of the beholder here. What was the definition of non-obstructive coronary artery disease?
The primary endpoint included cath with non-obstructive disease, and so that was defined as, like I said, 50% stenosis or more, or positive invasive physiologic testing.
Got it. Go ahead. You're on a roll.
So, looking at the baseline characteristics, the population enrolled was really quite similar to previous trials in this space, including Promise and Scott Hart. And importantly, we enrolled 50% women in the trial. The usual testing arm was split into about a third having nuclear testing, a third having stress echo, 10% or so having treadmill testing or MRI, and 10% were direct to cath. And this was actually very much in line with what we expected based on prior guideline recommendations and also the previously published practice patterns. Again, very few protocol violations were observed in the usual care group of patients in terms of them having a CTA as the first test. That was infrequent. And then in the precision arm, nearly half had a coronary CT alone. About a third had a CT plus FFR CT. 16% had no testing. So those were those deferred testing patients. And 7% ended up crossing over to get traditional testing, such as nuclear stress testing, stress echo, or cath. And so, what did we find? Well, first, the primary endpoint occurred in 44 of 1,057 participants, so 4.2% in the precision strategy group, and 118 of 1,046 participants, 11.3% in the usual testing group. And that was a hazard ratio of 0.35. And a win ratio of 2.81. The difference in the primary endpoint was driven by catheterization without obstructive coronary disease being much lower in the precision strategy. Um, Diving a little deeper in terms of some of the secondary effectiveness endpoints, we found that the number of caths was actually less with the precision strategy. 12.8% in the precision group versus 16.9% of patients in the usual care group.
Were you
Uh,
surprised by that, Mike? Or, I mean, sometimes, when you deploy new technology, people are thinking, well, you're going to use the cath lab.
Yeah, I think we were not surprised because again, our hypothesis was that introducing that physiologic discipline of FFRCT to a CT strategy would reduce the number of caths overall, um, and and also where there was a lower number of caths without obstructive CAD seen with the precision strategy compared to the usual care group, and that reduction was pretty dramatic. Um, but the other interesting thing that we saw
But,
was that
but Mike, I just tell you the perspective of payers and sometimes regulators is if you do a test to find something, you're going to find it and they're going to be on a rocket sled to the cath lab. But the point is, you didn't find that. I mean, I think that's very, very important here.
absolutely, yeah, I think it's very important. And again, it sort of addresses the weakness of a CT based strategy from prior trials where there was that increased likelihood of ending up with a catheterization. That's not what we found here. Um, But I'll say the other interesting thing was that we saw that cath yield was actually much higher with the precision strategy. So, of the patients that went to cath, there was a much higher likelihood that they would meet criteria for intervention. And because of that, the rate of revascularization was actually higher with the precision strategy, despite significantly less cath compared with usual care. The other neat thing that we saw was better uptake of secondary prevention meds in the precision arm. So 32% more patients were prescribed antiplatelet medications, and 20% more patients were prescribed lipid lowering agents in the precision strategy group. And
When you look at long-term outcomes, not acute outcomes, that actually may be very, very important, right?
Absolutely, and that's what was seen. That's what was seen in the Scott Hart trial. And
Right.
so, when you have improved uptake of what we know are effective secondary prevention medications, you expect that the long-term outcomes will be improved. Absolutely. Just to touch briefly on the deferred testing component of the trial, which I think is actually one of the most interesting parts of the trial in the spirit of current guidelines, recognizing the problem of over testing and suggesting deferred testing using pretest probability models, we stratified randomization of more than 400 low risk participants to deferred testing, as I said, or usual care. And that was really to provide much needed prospective randomized evidence to support the PROMIS minimal risk score as a safe and effective pretest probability algorithm for selecting those patients suitable for deferred testing. And I think it's really key to point out, importantly, There were no deaths or MI events seen in the deferred testing participants. So I think this is a really important take home because this was really the first such prospective trial to show the safety and efficacy of a deferred testing strategy in those low risk chest pain patients, which has been recommended by the guidelines for years, but not prospectively tested in a randomized way until now.
So, Mike, what are your take home messages for practicing docs out there?
Yeah, so I think the take homes are first that Precise demonstrated for the first time in a large randomized clinical trial that a risk-based testing deferral for minimal risk patients combined with a CTA approach with selective FFRCT for intermediate and high risk patients improves clinical efficiency with no statistically significant adverse effect on safety. A precision strategy reduced diagnostic testing overall. It reduced layered testing. It increased the likelihood of an abnormal test result in those who had further testing. So test yield. And I would say, put plainly, in both invasive and non-invasive settings, I think these results strongly support a precision approach, minimizing testing overutilization and increasing appropriate treatment.
Great summary. Are docs using it in this way? Are you starting to see more of this precise strategy being adopted out there after the publication of the results?
I think so. Certainly in my own clinical practice, I'm using CTA with FFRCT approach. I think certainly it minimizes unnecessary catheterization, and I have seen as an interventional cardiologist that it improves cath yield.
Well, I had one done and I had my FFR done, kept me out of the cath lab. So, I just had a very high calcium score, wasn't feeling sick or anything. So, I think in my N of one experience, I thought it was a valuable tool. Well, Mike, thanks for the summary. That was really great. Thanks for joining us today, and thanks to all of you for joining us here in Clinical Trial Results.
Thanks for having us.